Good morning, everyone. As I've been introduced, I'm Philisiwe Khumalo, and on behalf of the study team, I'll be presenting findings from a study conducted to assess birth defects following Dolutegravir transition among women delivering at surveillance sites in Eswatini. Just to give a brief background on the context of the study, Eswatini is a small country that is located in southern Africa. It has a population of about 1.1 million and has one of the highest HIV prevalence in the world, being 35% among pregnant women. We do have, though, a high facility delivery rate at 92.7%. Another thing to note about the country is that we do not have folate food fortification. In April 2019, the country started transitioning people living with HIV on ART to DTG-based regimen. So the map on the left shows the location of our country, which is bordered by South Africa and Mozambique. So this study was informed by findings from the Botswana Tsepamo study, where early data in 2018 indicated that there is a potential risk of neural tube defects among infants born to women living with HIV on DTG at conception. At the time, the rate was 0.94%, and it was significantly higher compared to other exposure groups of women. However, in 2022, there were new findings as new exposures, as more data was collected from additional women that were exposed to DTG, the prevalence of neural tube defects declined and stabilized at 0.11%. This rate was not different from the rate amongst women on non-DTG ART, and it was also comparable with the rate of 0.07% among women living without HIV. So we conducted a similar study in 5 public hospitals to evaluate the birth outcomes in all 4 regions of the country. We collected data from September 2021 to September 2023. The primary objective of our study was to determine the proportion of neural tube defects among live and stillborn infants born to women living with HIV receiving DTG at conception, also infants born to women without HIV, and also infants born to women living with HIV but receiving non-DTG ART at conception. Secondary, we also determined the general population prevalence of major birth defects among all the live and stillborn infants and also among medically induced abortions. We also described the prevalence of major birth surface defects by maternal characteristics, including HIV status, ART regimen, timing of exposure to ART, and also other factors, including maternal gravida and age. So similar to the Tsepamo study, during data collection, we had nurse midwives that performed routine surface examination on all newborns. We then had research assistants that extracted data from clinical records, that is paper-based and electronic clinical records. They extracted data on pregnancy history and also HIV and ART status for all births, whether there would be a birth defect identified or not. So in the case that during the surface examination, in the case that the birth defect would be identified, the nurse midwives would notify the research assistants, and the research assistants would approach the mother to consent for an interview and also taking of the photos. So blinded data from the interviews and also the photos was reviewed by a genetics expert to confirm the diagnosis. So the data that was blinded, we removed the maternal ART and HIV status so that it wouldn't cause bias when the geneticist was reviewing the data and also confirming the diagnosis. So for the study, defects were classified as major or minor based on definition used by the Metropolitan Atlanta Congenital Defects Program. And major birth defects were classified as major external structural malformations if they were deemed significant from a clinical, surgical, or cosmetic standpoint. Of note is that the definitions used in the study were similar to the definitions that were used in the Botswana Tsepamo study, with an exception in that in our study we included any medically induced abortions due to defects identified via an ultrasound. Moving to the findings, so this slide shows maternal characteristics, that is characteristics of all the women that were enrolled in the study. So in total, we enrolled 50,075 women, of which 91.5% had a live or a stillbirth. The median age was 26 years. A majority of the women were aged 18 to 34 years, that is 77.9%. About 12% of the women had preterm delivery, and 98.4% of the pregnancies were singleton. And then looking at maternal HIV and ART status at conception, among the women with a live or a stillbirth, 70% of them were HIV negative, and 30% were living with HIV. Then amongst the women that were living with HIV, 72% were on DTG at conception, 13.6% were on non-DTG regimen at conception, and 13.9% were not on ART at conception. This means that these women started ART later in pregnancy, and most of them were newly diagnosed with HIV during the pregnancy. Looking at the newborn characteristics, 98% of them were live and 2% were stillbirths. About 48.6% were female, 85% had vaginal delivery, whilst 15% were delivered through C-section, and about 12% had low birth weight. So for the study, we determined the prevalence of birth defects overall and by type among all the exposure groups. Apologies. So let me explain this slide first. So this slide is about how we went about screening and enrolling women with newborns who were identified to have a birth defect. So among all the 45,840 women with a live or stillbirths, we had 405 newborns identified to have a birth defect, but we managed to analyze data for 388 newborns. 17 were excluded, where 8 were either missed or declined enrollment, and 9 were ruled not to be a defect by the geneticist expert. So for the study, when it comes to determining the prevalence of the birth defects, we determined them by overall and also by type among the different exposure groups. So looking at the table, at the bottom of the table, overall we identified 388 birth defects amongst 45,724 live and stillbirths, and this gave us a prevalence of 0.8%. There were 40 neural tube defects that were identified for a prevalence of 0.09%. And then there were also 189 major non-neural tube birth defects that were identified for a prevalence of 0.41%. The rest that are not showing in the table were minor birth defects. And then when we focus on the neural tube defects, there were 27 neural tube defects that were identified amongst the total of 32,259 live or stillbirths born to women without HIV, giving a prevalence of 0.08. And then there were 13 neural tube defects that were identified amongst 13,465 live or stillbirths identified amongst women living with HIV. And when we look at the prevalence difference between women without HIV and women living with HIV, looking at the prevalence difference for the neural tube defects and the major non-neural tube defects, there was no statistical significance. Then we also looking at women living with HIV stratified by ART regimen at conception. There were 8 neural tube defects that were identified amongst women that were on DTG at conception versus 4 neural tube defects that were identified amongst women that were not on DTG at conception. Again, even in this exposure group of women, there was no statistical difference when you look at the prevalence of neural tube defects and also the major non-neural tube bed defects. We also conducted a multivariate log binomial regression to determine the association between major bed defects and some maternal characteristics among women living with HIV who had a live or stillbirths. The maternal characteristics that we looked at included the ART that they were exposed to at conception. It included maternal age at delivery, gravida, and delivery, and also the study site. Look across all these variables, there was no statistical significant associations between the risk of major bed defects and these characteristics, except for delivery year, where in 2022, the risk of bed defects was lower compared to 2021 and 2023. But we are not able to explain why this happened. We looked at our data, the trends, to see if maybe seasons could have affected. We looked at issues of COVID vaccinations and other factors, but none of this could plausibly explain the difference. So in conclusion, overall bed defect prevalence among women living with HIV and DTG at conception was 1%, with neural tube defects prevalence of 0.08%. The prevalence rates were similar in women without HIV and women with HIV living with HIV on other ART regimens at conception. The overall and neural tube defect prevalence rates were comparable to those reported in the Botswana Tsepamo study. Combining the Eswatini data with the data from the Tsepamo study, there are now over 19,000 bed defects among women living with HIV exposed to DTG at conception, and 18 neural tube defects identified, giving a weighted neural tube defect prevalence of 0.09%. So the data from our study does not support an association of neural tube defects and preconception DTG exposure. And finally, the study also demonstrates that large-scale surveillance, as new antiretrovirals are introduced, such as injectable PrEP or ART, is feasible and critical to generating real-world outcomes as part of a scale-up. I would like to thank the study participants, all the research staff that make this study possible, and also the support from the Ministry of Health as we conducted the study. We'll also like to thank Viv Healthcare for providing the financial support for the study. Thank you everyone for your attention.